Hello, my name is Trish Feldkamp. Welcome to my presentation on the implementation of a callback system for patients who are post-percutaneous coronary intervention. I chose to complete my clinical hours in the University of Kentucky Cardiac Catheterization Holding and Recovery Room. This unit is a very busy and fast-paced outpatient environment consisting of 10 beds for cardiac cath patients who are pre- and post-procedure. There are 5 heart catheterization labs, and procedures are performed with attending physicians and fellows only, no resident physicians. The nurses in this unit work 3 12-hour shifts, rotating between 6A, 7A, and 8A shifts throughout the week. They can have up to 3 patients at a time, averaging 10 patients per shift. The procedure list can start out with 15 to 20 patients scheduled each morning, but often there are 5 to 8 add-on cases per day, with patients coming from the emergency department and the inpatient floors. As a current operating room nurse and former ICU nurse, I had limited experience with the assessment routine for this patient population. One of my immediate learning goals was to learn how to look for post-PCI specific risk factors such as bleeding, hematoma, and post-sedation reactions. Upon beginning my clinical time, I learned that one of the current goals was to work towards reinstating a callback system for post-discharge patients. A study done by the UK cardiology team in October of 2013 to February of 2014 indicated that callbacks were beneficial to the reinforcement of patient teaching, but they were stopped in 2015 when the designated callback nurse left the unit and no one was hired in her place. In discussing this with the staff nurses in the unit, I found that most supported the reimplementation of a system, but there needed to be a policy and plan in place to guide this transition. My next goal was to collaborate with the nursing team to develop an appropriate policy change, which most thought would also benefit the patient satisfaction scores. They had previously found that patients who had a sound understanding of their medications and the importance of adhering to their regimens exhibited high rates of satisfaction. My next goal was to develop a document to include in the discharge paperwork to be filled out by the discharging RN. This document would contain relevant patient information, including consent for callback. I wanted to educate the staff on the benefits of initiating a callback protocol using evidence-based examples. So I put my project plan into action. Over the next few slides, I will discuss the discharge process and the importance of the CATS Pledge document, which indicates the medications that are vital to the survival of the post-heart cath patient, as well as reducing readmission and ensuring reimbursement. The cath lab holding and recovery RNs have many responsibilities, including the evaluation and documentation of adult patient care and initiating treatment. I assisted my preceptor in monitoring for bleeding post-sheath removal and performed vitals per protocol, which were Q 15 minutes for 30 minutes, Q 30 minutes for 1 hour, and then Q 1 hour until discharge. We also rounded for comfort with the assistance of the patient care technicians. One of the most important duties of the RN, however, is to ensure that the patient understands their discharge instructions. Due to the outpatient nature of the cardiac cath lab, there is often a substantial amount of information to be conveyed in a short amount of time. The nurses are able to log on to Crames on Demand to print procedure-specific discharge packets, such as management of the TR band. Additionally, these forms are reviewed and filled out at discharge. They include such instructions as no driving, no drinking alcohol, no lifting over 10 pounds as to not pop the seal at the insertion site, no submergence of the site in water, no tub baths, and no neosporin. We also teach to monitor for the signs and symptoms of infection, bleeding, and signs and symptoms of a stroke. But in order to alleviate patient anxiety, we also reassure them it is unlikely to have a stroke past the time in which they were monitored in the recovery room. The nurse and the patient both sign, and the yellow copy is sent home with the patient. One thing I found especially interesting was the utilization of a tool called the CATS Pledge. This program was instituted to ensure that cardiac patients are discharged with a 30-day supply of these vital medications free of charge. If the listed medications are not obtained immediately, the result could be a clot or death. The CATS Pledge program ensures that all patients, regardless of income and access to transportation, can receive their first 30-day supply before they leave the hospital. They also receive a pharmacist clinic visit at 7 days and a pharmacist phone call at day 29 to verify that their prescriptions have been refilled. Studies show that the complexity of the discharge process, coupled with the patient's stress about leaving the hospital as soon as possible, increases the likelihood of readmission. Telephone follow-up offers a low-cost strategy to address patient needs and reduce readmission. One study I found described a technology-related health coaching program for high-risk postpartum women. Though that demographic differs in regards to the medical procedure performed, they are similar in that the patient population is one of low literacy and low income. Many of the patients in the UK Medical Center Cath Lab come from rural areas of Kentucky, and while not every patient has access to the internet to check their patient portal, 85% of low-income users have basic cell phones. Post-discharge calls can reinforce messages received during healthcare encounters. There's a critical window of opportunity to intervene and provide maximum resources, support, and tools for the prevention of chronic illnesses. Research also showed that phone and text groups in one study had lower proportions of patients revisiting the ED, a greater than 50% reduction. A study performed by the University of Kentucky Cardiology Department from October of 2013 to February of 2014 was presented in 2017. It revealed that patients could not state the signs and symptoms of when to call their doctor, nor state the importance of cardiac rehab. Many were unable to view the multimedia discharge material adequately in recovery due to the lingering effects of sedation and the lack of family presence. Recovery RNs were often unable to find that teachable moment. Preventing 30-day or less readmissions has become a national patient safety goal for myocardial infarctions and percutaneous coronary intervention. The UK Cardiology Interdisciplinary Team developed an education plan and low health literacy toolkit, which utilized plain language and the use of teachback, and also included plain language pamphlets and an iPad-based video clip program. A follow-up phone call by an expert cardiac nurse within 72 hours of discharge would evaluate understanding using teachback and also clarify any misunderstandings. In the 6 months following full implementation of the education program, compared to the 6 months prior to the initiation, there was a statistically significant reduction in 30-day readmission rates. Readmission rates pre-implementation were 7.7%, and readmission rates post-implementation were 2.2%. Prior to the implementation of the callback system, 34% of patients went to cardiac rehab. But after explaining the importance of rehab and assisting with setting up appointments, 85% of patients went to cardiac rehab. My project to encourage best practice involved creating a follow-up callback form to be included in the discharge paperwork. Its clear, concise, and easy-to-follow script would allow any nurse to complete the call, even if the telephone RN is unavailable or if there's not one currently employed. The top portion is to be filled out by the discharging nurse, and placed in the callback nurse's mailbox for follow-up within 72 hours. It indicates if the patient consents to a callback and includes information such as discharge diagnosis, phone number, and the best time to reach the patient. The bottom portion is completed and placed in the patient's chart. The script includes such questions as, have you had any issues with bleeding or signs and symptoms of an infection? It also inquires about the ability to take or obtain discharge medications. Lastly, patients can request to be contacted by their physicians. My time in the UK cardiac cath lab holding a recovery room had a significant impact on the way that I think about nursing and teamwork, maybe more so than any unit where I've ever been employed in my career. I observed the way that each nurse would assist with the duties for each patient, regardless of whether or not they were assigned that patient for the shift. My preceptor described the teamwork method in which each nurse is to check certain documents on every patient, such as a consent form, to verify that it is complete and correct. They serve as a hard stop for each other. Since this method was established, major errors have significantly decreased, and communication amongst team members has been greatly enhanced. My preceptor outlined an instance in which a procedure was performed without a consent, but after the multiple check system was initiated, that type of error no longer occurred, resulting in better patient outcomes. But the teamwork that I have witnessed goes beyond that. One of my goals was to learn to perform accurate assessments of the patient population in the cath lab. Not only was my preceptor a wonderful teacher, but each nurse seemed to take me under their wing at different points during the day to share helpful tips on the methods that they found best for teaching and treatment. They were kind, patient, and supportive. My plan for implementing nurse-driven interventions included collaborating with the nursing team and discussing policy change, which each of the team members was more than willing to do. Coincidentally, the unit did hire a callback RN in the time when I was completing my clinical hours. When I presented my callback form to my preceptor, the callback RN, and the rest of the nursing staff, my idea was received with the utmost excitement and gratitude. I was given incredibly positive feedback, and I was made to feel like I was really making a difference for patient care and safety. I look forward to incorporating many of these learned principles into practice, and I am very grateful for the time that I spent on this unit. Thank you all for listening to my presentation, and good luck in all of your future endeavors.